Actually, the purpose of my talk today is to show you the impact of our new treatment to treat chronic hepatitis C and how they completely dramatically change our practice in liver transplant patients. Here, my disclosure. So first of all, and to begin, we have to remember where do we come from. And as you know, HCV recurrence used to be a major issue during that more 2 decades. And if we compare the result of both graft and patient survival after liver transplantation with a chronic hepatitis C, you could see that there always an impact and a poor prognosis in this patient with a poorer HCV recurrence compared to patients transplanted for other indications, as hepatitis B, for example, in this slide showing you results from the European Liver Transplant Register. So, and for those who are not familiar with hepatitis C recurrence, we used to observe 3 kinds of recurrence in our patient. When we transplanted them with a positive RNA at the time of liver transplantation, most of patients develop an acute hepatitis and could lead to a chronic hepatitis and then cirrhosis. In more than 30% of our patients, they already had a cirrhosis 5 years only after liver transplantation. For other patients, there are sometimes an asymptomatic hepatitis, but that could also lead to a cirrhosis. And finally, in less than 10% of our patients, there are a poor prognosis form, which is very severe, which is named the cholestatic hepatitis, fibrosis cholestatic hepatitis. And another time, it's a catastrophic prognosis that could lead to death or liver transplantation. So, and we know that for the interferon area, the only way to change the prognosis of our patient is to achieve the cure of the virus and to achieve the sustained virological response. So, of course, with DAA, everything changed, and now we could use that drug or before liver transplantation or after liver transplantation to treat our patient. So that's my point today. I want to show you how this treatment impacts our practice, how this treatment impacts patient and graft survival, but also how this treatment impacts waiting list and liver transplant activity. So let's begin with our practice. The first thing is that this treatment clearly simplifies easier our day-to-day practice with more effective treatment and more well-tolerated treatment. This slide sums up all the results you've got using those DAA in liver transplantation, all the combination evaluated and approved today using sofosbuvir plus an NS5A inhibitors, ledipasvir, daclatasvir, but also other combination with protease inhibitors and more recent combination with protease inhibitors and NS5A inhibitors. Whatever, as you could see, more than 80% of sustained virological response compared to the interferon period. We have to remember that the response were about 30 or 60%, so it's a drastic change. The second thing is that these treatments are very well tolerated after liver transplantation, less than 20% of serious adverse events in the study, but mostly due to ribavirin. And you could read the ELITA guidelines that we just published in Journal of Hepatology that sum up all the efficacy of the treatment and all the way to manage the treatment patient before or after liver transplantation. The last thing and the important thing that now we know that we treat liver transplantation as we treat the general population. Without ribavirin, with the same duration of treatment, it's not anymore a particular population. So we've got data now to say that ribavirin is not mandatory when patients have low fibrosis on the liver graft, and the duration of treatment could be shorter, about 12 weeks of treatment. So are there still any issues in liver transplantation and treating hepatitis C? There is, and the first one is still the drug-drug interaction, and you know about that kind of slide. 2 messages. The first one is that as sofosbuvir is metabolized by kidney, there is no problem and no drug-drug interaction using immunosuppressive treatment and sofosbuvir. There is issues using protease inhibitors with our drug immunosuppressive treatment. But most of the studies show that there is not significant and not clinically significant drug-drug interaction anymore, but we have to be very careful. You're using those drug protease inhibitors with our immunosuppressive treatment, and we recommend to adjust and to monitor closely immunosuppressive drug when we introduce protease inhibitors. There is less interaction using NS-phase A inhibitors, ledipasvir, velpatasvir, and daclatasvir. The second issue, and that's important in our field, liver transplantation, it's the kidney function. And we have some issue in the first place because if we focus on the creatinine clearance of our patient during treatment, we observe a slight but significant decrease of creatinine clearance using those drugs. Finally, we go through this work and we finally show that there is no impact for the long term, and the decrease we observe is during treatment and after the patient restores completely their kidney function, and it depends on the comorbidities of the patient. So what's the real issue now? The real issue is the timing of the treatment and when to treat our patient for hepatitis C, before or after liver transplantation. The first thing, when we treat patients before liver transplantation, we would like to avoid liver transplantation for our patient and delist our patient for liver transplantation. This slide shows you the result of the European multi-center study from ELITA that we performed last year. And as you could see on that slide, for some patients, there is a high chance of delisting and of avoiding liver transplantation. But it clearly depends on the severity of the disease at the first place. The less the patient is severe, the more their chance to be delisted. But finally, for the sickest patient, that chance is very, very low. We estimate that there is 30–40% of our patients that could be now delisted, but another time it's child A patient with low med score at the introduction of GAA. The second thing we have in mind when we decide to treat patients before liver transplantation more than after liver transplantation, it's finally where another time patients are severe and with decompensated cirrhosis. The results are still excellent, but finally there are lower efficacy in decompensated cirrhotic patients compared to liver transplant patients. And the last thing, and you know about that, it's some warning regarding safety in cirrhotic patients, and particularly in decompensated cirrhotic patients. Some warning regarding cardiac events, and you know about that paper, but lots of uncommon but severe adverse events when treated cirrhotic and decompensated cirrhotic patients. Hepatic decompensation, but also lactic acidosis using direct antiviral drugs to treat cirrhotic patients, and also some uncommon but severe pulmonary arterial hypertension in patients treated with sofosbuvir, and we have lots of evidence for that. The second warning, the last warning, but not the least, it's clearly the anesthetic rate of early tumor recurrence when patients were treated with drug with direct antiviral for an hepatocellular carcinoma. But as you know, there are now robust data showing that probably there is no higher risk of incidence or recurrence by treating these patients regarding hepatocellular carcinoma, but there are still a doubt regarding the severity and the aggressivity of the tumor when they recur or occur. So just to sum up this part, and very briefly, that's an algorithm I suggest, and we apply in our center to treat patients on a waiting list. With HCC, in most time, we could treat them before liver transplantation easily, especially when patients had a compensated cirrhosis. And when patient had a decompensated cirrhosis, the right part of this slide finally depends on the severity of the disease. When patient had child B and low MELD score, no problem, go on and treat them on the list. That in this patient that we could expect the more delisting patient, but with child C virus and especially high MELD score, maybe 20, and I recommend 18, which is very low, but 20, 25, we don't know. We have to discuss case by case before treating this patient. Then let's move to the second point, the impact on patient and graft survival, and another time it's very good news. The first data we've got with, by treating liver transplantation with DAA was the clinical and biological improvement thanks to this treatment. And that's an example of our work we perform in the CUPILD cohort, a national cohort in France with patients treated with DAA after liver transplantation. For patients with the higher MELD score at baseline, MELD up to 15, finally, you could see that most of the patients improve regarding their clinical parameters, another time the biological parameters, and that's a very good point. And of course, after that, the SVR. And which is very important that we demonstrate in the first place that this improvement not only affects liver transplantation with low fibrosis on the graft, but already patients with advanced extensive fibrosis on the liver graft. Here you've got the data of patients with a F3 score or F4 score cirrhosis on the liver graft, and most of them are able to be cured and improve using those drugs. And that was the same thing regarding the fibrosing cholestatic hepatitis, the form that I tell you in the first place, 10% of our patients. And look at the percentage of survival at 1 and 3 years after transplantation without the use of DAA. And finally, with DAA, we've got a completely different story with patients who improve fully in terms of clinical biological parameters, but also in terms of survival. And in that short study, about 23 patients treated with DAA after liver transplantation with FCH, we've got 100% survival to date. And another special population, and an important one in the liver field, is the co-infected patient with HIV, because these patients are particularly exposed to develop fibrosing cholestatic hepatitis after liver transplantation, and they were difficult to treat patients before the era of DAA, and another time, excellent result, and we are able to cure and improve this patient. So, and to conclude, what will be the impact for us and for us all, for the patient, of course, and patient with a chronic hepatitis C, but also for the waiting list and the liver transplant activity. And we have some data now showing in the first place that there is a decrease, already a decrease of HCV patients on a waiting list. This work came from the US, of the Scientific Registry of Transplant Recipients, a work between 2003 and 2015 with more than 40,000 patients. And if you look at the dark line, which is hepatitis C, you could see that both for decompensated cirrhotic patients on the waiting list for hepatitis C and both for hepatocellular carcinoma, we already observe a decline till the approval of DAA. On the contrary, we could see that there is an increase of other indication, of course, for liver transplantation, and that's the case on that slide of NASH due to metabolic syndrome. The other good news is that the survival of our patient and, of course, the activity regarding hepatitis C for our agency. And that slide shows you the results of the French National Agency. Results have been presented yesterday. The first thing is that we observe in general, an increase of the liver transplant activity in France. But if we focus on the activity regarding hepatitis C, we observe in the era of DAA decline, a 60% decline during the era of DAA, and the one-year graft survival rate is significantly improved between the period before the approval of DAA and after the approval of DAA, and we improve the one-year survival to 70% to more than 85%. So that's excellent news, and we have to focus that we improve those results regarding depending the age of the donor and the recipient, and also higher MELD score during this period. So the last thing I want to show you is that treating and using DAA in the area of liver transplantation may help you using donors with an antipositivity, seropositivity for hepatitis C. It's clearly an underused resources. The seroprevalence of HCV is higher in donor and all over the Western world. In France, we estimate that it's 1% of our donor, but in some data coming from US, it could be 5% of the donors. And if we focus on our results, today it's clearly an underused resource. We only use 60%, 20% of this kind of donor, and it could be good donors. And of course, the activity of hepatitis C is one of the most important facts that we discard this kind of donor. And another time, with the DAA area, we found an increase of this graft utilization. This was coming from the US another time. In the blue, light blue, we observe the use of these donors without DAA, and an increase of that use of donors in the DAA area, and also the patients, the recipients who receive that kind of organ, which could be or now HCV positive patient or HCV negative patient regarding the viral load. So here my conclusion and the take-home messages. First, the use of DAA in the transplant field has dramatically changed our practice. Efficacy, safety profiles of DAA, excellent profile before and after liver transplantation. Few issue remains. Think about drug-drug interaction, and of course the timing of treatment before or after liver transplantation we have to choose, and that argue in both cases to the use of NF5A inhibitors more than protease inhibitors in our field. The use of DAA is and will dramatically change the graft and patient survivals, and we have now few data showing that even in difficult to treat population, fibrosing cholestatic patients, HIV patients, and we have already observed a decrease in LT activity for hepatitis C and an increase of the anti-HCV positive donor use, and that will be able to increase our pool of organs for the future. Thank you.
So, questions? I have just one question. I'm really interested in the positive donors. I think this is something that we need to really convey the message that these donors are really now we should be using them more often, but for all organ transplants.
Yeah.
And do you think that the donors that are discarded, they're really discarded because they're anti-HCV positive, or they're discarded because their livers are of poor quality?
No.
Is there data to show whether...
No, in the French data, first it was in the air without DAA, so most of patients are still positive at the time of transplantation. But the problem is that the match we have in France is a derogatory graft, so we have to accept to receive this kind of donors, and we have no recipient identified to receive that kind of donor. So the message, but you're perfectly right, for the entire community that for now donors are with viral load negative at the time of the harvest. So we could use that organ very safely, I think. And the only thing we have to be sure that the fibrosis regarding the liver, but for other organs, there is no problem for this use.
But you would also accept HCV RNA positive organs? Or you think we should not accept HCV RNA
we accept HCV RNA positive donors for an HCV RNA positive recipients now. I think. And
not for the negative recipient in a
depends
very
on the
urgent
past history,
situation?
but honestly, at that time, for ethic reasons, I think it's difficult. Patients be cured for hepatitis C, but there are still an indication for liver transplantation for hepatitis C, and telling them that we are going to transplant another time of virus with hepatitis C, but we can treat them after liver transplantation. It's a debate. In my opinion, I would avoid that kind of situation, but it's very, very few and rare and common situation.
But there are, in the United States, they have the epidemics of positive donors, and there's a very interesting trial just published in New England treating the recipients with 100% response. I think we should go over it if and only the donor graft is of good quality. We have a question.
Thank you for your nice presentation. Dr. Portoles, nephrologist from Madrid, Spain. I have two very practical questions for you, and I would like to hear a response coming from your expert opinion, because guidelines are not so clear. The first situation is the use of the kidneys from donors who has received a successful treatment, and they are actually negative for HCV. And the second question is the global relapsing rate after a successful treatment in order to keep the isolation in the dialysis rooms. Thank you.
The first question, I understand. The first question is regarding the chance to have recurrence by accepting HCV positive donor for cured for hepatitis C for a kidney recipient. That's your question? Yeah, there is absolutely no chance of recurrence. The donor is cured, so you can use this organ safely. And as Marina just said, the only thing is the quality of the organ. So you could be confident by taking that organ. But sorry, I missed your second point.
Second point is the global relapsing rate after a successful treatment in order to keep the isolation of the patient in the dialysis rooms.
If there is patient treated for hepatitis C that could improve their kidney function?
No,
to go to non-isolated, instead of putting them in Spain, HCV positive, go to an isolated areas of dialysis. If we should change them to non-isolated, which I completely think
it's yes, another time. When patients, that's a particularity and chance with hepatitis C. When you're cured, you're cured. There is no chance for recurrence except reinfection, of course, but no problem.
Okay, thank you.
Before we close the session, we got a question for Oriol. Before, somebody was asking what the cutoff is for the quantiferin for CMV.
Yeah, what the manufacturers say is 0.2 units of interferon per ml. This is the official one, and it has been studied in seropositive patients. For seronegative patients, the plus or minus patients, in our study, the cutoff was a little bit lower. With 0.1 units, we had a better sensitivity and more or less same specificity. So I would say that would be somewhere between 0.1 and 0.2, the cutoff for positivity. But it's also interesting to see the quantitative result, not only positive or negative, but the quantitative. Of course, if you have more, the higher the level of interferon, probably the better protection you have. Huh?
Okay, well, thank you very much. Well, I want to thank all the speakers for really beautiful talks, and also the audience to remain here today. Thank you very much.